How is studies going? Are we doing well? Are we understanding everything? Is anybody having any challenge? He knows my name. Right. Let me share
Good
the
evening,
screen.
sir.
How are you doing?
I'm fine, sir.
No.
We are trying with studies. It's just that some courses are holding us down, like mental health.
Mental health. Mental health is the cheapest aspect of nursing.
However, I'm having some challenges, especially with the medications for mental health.
Psychopharmacology. Okay. No problem. We will get there. I think we are done with mental health. Oh, Victor, are you there? I think we are done. Oh,
Yes, I'm there. I'm there.
Yeah, we didn't do
were
it.
you mental health
We were supposed to do. We
for
were
this cycle?
supposed to do it. I don't know.
Oh, but one of my admins
We
told
didn't
me
do
we
it.
are done with.
We were supposed to
Oh,
do it and you travel. The week we were supposed to do, you travel.
Okay. Sorry. Sorry about that. Then when we are done with management, we do mental health. Okay. Thought we are done. So
All right, sir.
okay. He knows my name. Right. So let's start business. He knows. David, are you okay today? You requested for some 10 minutes in.
Yes, sir. Yes, sir.
Okay.
I'm very much alert. My eyes are open wide.
Okay. So I have some 10 questions for all of you. Okay. This is the priority bundles or frameworks. I'm going to use it to solve all the 10 questions. Okay. So it can be ABCD. The answer can come from Maslow. The answer can come from acute or chronic. The answer can come from stable or unstable. And the answer can come from actual or potential. Our acronym is AMASA. Don't forget. Okay. So question 1. The nurse receives, is everything okay? Let me see. Okay. The nurse receives report on 4 clients. Which client should the nurse assess first? So the nurse as the manager, which of these 4 patients? So we are looking at a client with chronic arthritis requesting pain medication, a client with COPD and oxygen saturation of 88, a client awaiting discharge instructions, a client with anxiety about surgery tomorrow. Okay. So I'm asking. Yes. Lois.
Sure, D.
Sir Bright,
D.
the answer would be D. But I wanted to find out if we are just answering or we are analyzing. The answer is a D.
The answer is D or B.
Yes,
which is
please.
Which? Daniel.
D, the last one.
Okay. The client
D.
anxious about surgery tomorrow. So this one will fall under what? Analyze the D.
Safety, please.
Safety needs.
Safety. Okay.
Yeah.
About tomorrow. Yes. So it's not ABCD. It's Maslow. Right? If you are talking about safety, then it's Maslow. Acute or chronic. There's no acute issues here. Then the S. Stable or unstable?
Yeah, but there's
Okay.
a chronic issue.
Okay. Then we have the actual or potential. Okay. So this guy has Maslow's issue. Let's analyze the other ones. Or A, we can talk about
You
A.
were saying there's no.
A client always use your Amasa to analyze the options so that you get your answers. Wait. Yes,
Yeah, right,
Lois.
please. Can I?
Yeah.
Okay. With the A, the
Mhm.
client has chronic arthritis, and with chronic, we always know that acute beats chronic, and arthritis pain is an expected finding. So he requesting for pain meds. It's okay, but it's not the priority here in this question. So pain
So if
is
it was you, you will
it's a
cancel this.
Please say again, say.
If it was you, you will cancel this.
Yes, please, I'll cancel that one.
What you tell me is what I will do for you. So don't worry. Analyze. Shoot.
And then with the B, the client with COPD, and COPD is also chronic. And in this case, an oxygen saturation of 88 is an expected finding. So we are not surprised if he has an oxygen saturation of 88. We can go past him too.
So he has a chronic saturation. Okay. C.
Sir, can we say the B with a chronic oxygen saturation of 88 is an expected finding, but it is normal in cops.
Yeah.
Okay.
Yeah, that's why it's an expected finding.
C.
And with a C, this is a client who is waiting for discharge instructions. The client is fine, totally out of danger, doing well and ready to go home. And so the patient can wait for us to take care of the anxiety before we come to the patient and do our discharge, our education for discharge for him or her to go home. So we'll cancel that patient out too.
You also support the D, right?
Yes, please, sir.
Okay. Any objection? If not, I'll not answer it. I've told you I'll not answer it. When you get it, then you also try yourself. Okay, so I will not choose the answer.
Yeah. See, you were saying the question has nothing to do with chronic, but the A is talking about chronic. So I didn't understand that aspect.
Well, he said acute rather.
Yeah,
So
I heard of chronic.
the A, I think David yesterday was not part of the this thing. Was not part of.
Yes, the earlier part of it, I wasn't part, so that's why.
Yeah, that is why you are
was
getting
worried.
confused. Okay. You have been given 4 patients. You are looking for a
But I know
patient
the
with
answer there from this one. No, sir, I
again.
was just saying that with the question, the answer is D. But I want to be convinced within the acute and that of the chronic aspect. If you can throw some more light on it.
So this is when we take prioritization. You can't answer prioritization questions without knowing all these things. The acronym is AMASA. Okay. So yesterday I told them that when we go to the chronic or the stable or whatever, our issue is what is the problem of the patient. Okay. So one, you should know the problem. The immediate problem we are talking about. Then after you've seen the problem, you ask yourself, is this problem an airway problem, breathing or circulation? Is it a Maslow problem? Is this problem acute or chronic? So with the acute or chronic, yes, the problem can be chronic, okay? But we are looking for somebody with an imminent problem which is bothering them for us to help the person, because as a nurse manager, our resources are scarce, are not enough. So if I get 2 patients who has one has acute problem and another one has chronic problem. I'll give attention to the one with the acute. So two patients can have hypertension. Yesterday, I cited an example of hypertension. Chronic hypertension. All of them has, okay, let's use this one. This guy has a chronic arthritis. Okay. But, because they have used the word chronic, it means it is something that has been with the patient for long. It is not now starting. Okay. Yes. Somebody is asthmatic or somebody has a COPD. Everybody knows that it's a chronic condition. But on top of the COPD, is there anything new that has arisen and is causing problem to the patient? That is where we give attention to what? The acute. So two people have hypertension, but outside the hypertension, one is having respiratory distress. Okay, suddenly. So we will give attention to the one who is having what? A new or acute issue. Please, do you understand, David? On your mic.
Yes, sir.
And let's talk.
Yes, sir. Yes, sir.
Yes.
Yes, sir.
And which one, where else which one were you asking for another?
No, I was asking of the acronym the AMASA, but you made us explain that the
So,
A stands
yes.
for acute and then M for Maslow's theory. Then the
So,
other in is
like this. Okay,
acute.
that's it. They can give you 5
Yeah.
patients, all of them are having ABCD problems. That is where you need to go deep. You ask yourself, what goes wrong with the A? These 5 patients, which of them is having airway problem? Which of them is having breathing? Which of them is having circulation? Okay, I'll choose the airway. Okay. Sometimes the airway, the patient can be having an airway problem, but he is stable. And that airway problem, like this one, COPD, is an airway problem. Ideally, you should have chosen this, an airway problem. Okay. But he is stable with this oxygen saturation per physiology. So we will not give attention to him. David, do you understand?
Yeah. Yes, sir. Yes, sir.
So this, especially, you are part of those NCLEX people. Okay. Forgive me, students are also part of us. That is why I always want to cut across. Okay. So those who are going to write NCLEX, they will give you a problem and define that problem. So don't always say that this is airway, so I'm choosing airway. No, you get it wrong. Analyze it. Analyze with the massa, and you move on with it. Okay. Yes.
Okay.
Thank you. Sorry, my admins have come, so let me make them co-hosts. Sorry.
So the AMASA, no, it is airway, Maslow's theory, acute, and then sudden. Or the
Yes,
terms.
it is the A is ABC.
Airway, breathing, circulation.
The A is
Then the
ABC.
Maslow's theory.
Like this. Amasa. This A here, it is the ABC bundle. Okay, then we have taken the A and used it as the Amasa.
All right.
You understand?
All right, sir.
So this question has given us a mixture of problems from all these people. Okay, we are not only concentrating on A because the first guy here is not having ABCD problem. The second guy here is having ABCD problem. Okay. The client awaiting discharge tomorrow is stable here. Is having an S stability issue here. he will fall under S. Okay. And the client anxious is having Maslow's. Okay. So ideally, we would have chosen the one, this B and the C. Then you analyze them. You said that no, this guy is, yes, he has ABCD problem. Okay. But he is stable with this vital sign. Okay. But this guy is having what? The D. The D is having Maslow's problem. He falls under Maslow. That's the second bundle. But what is his problem? His problem is anxiety, and it is making him unstable. Okay. So if I pick this instability and I pick this Maslow, it gives me what? The edge to give him attention first. David, do you understand?
Yes, sir. I got you.
I'll give you to.
Thank you.
I'll give you to Ayarega or Nico to do. Otherwise, yeah. Please, anybody is having doubt? Okay, let's move on to the second question. Let's use Amasa to solve this. Yes, who analyze for us? Amasa.
Can I try?
Okay. Okay, try. Practice, so don't just be an observer on the page.
Okay, so a patient with chest pain and diaphoresis. 1. A patient requesting sleeping medication. 2. A patient awaiting physical therapy. And a patient with chronic hypertension. Okay, so Sir Bright, if I'm to start with the A, with the A, they said a patient with, so this is not an old problem. The patient is experiencing the chest pain and the diaphoresis. So in between the A, B, C, and D, the A is the priority here because chest pain and then the diaphoresis, he's experiencing it. So it's a physical problem, a physiological problem. Please, I stand to be corrected.
Okay. Yes.
Okay.
Continue.
So with the B, the patient requesting for sleeping medication. This patient is requesting for sleeping medication to sleep. So the patient can be a priority here because we can always hold to give the patient the sleeping med. So the B is also is there a psychological problem?
Did the question? Don't think for the question.
With the B,
we can say the question you should ask yourself: is he having a problem?
No,
I can call David. David, can you give me sleeping tablets? Does that mean I have a problem?
No, please.
You only need psychological therapy to sleep.
Yeah. And then with the C, the patient is awaiting physical therapy. The physical therapy is also important, but it's not a priority to the one who is experiencing the chest pain right now. So we can also boycott him for now. But then we can see him after seeing the chronic hypertension patients. So we can also omit him. And with the D, it's chronic. So obviously the acute takes importance. Thank you. Sir, please, I have to go.
So with the Amasa here, I will use the S to judge with that of the A answer, meaning it is a sudden thing, indicating it is a sudden chest pain. Client with chest pain is a danger of developing respiratory issues.
Okay, Dave, listen. They didn't qualify, and I think I need to bring that slide out. They didn't qualify the chest pain. They said wait. And what did I say? when you see the word wait.
So you said that
I
it
remember
means that
yesterday.
the actual thing is happening or is occurring. It's already occurring.
So under this bundle, actual or potential, this guy is having an actual problem. When you see potential, let me ask you, when you see potential, what would they use?
At
The
risk.
person is at risk
At
of.
risk of. Yes. So one, this guy has an actual problem. That's when we say the amasa. He's having an actual problem. You check mark. Okay. Let's go on. He has chest pain and diaphoresis. Okay. So where would these two guys fall?
Under airway.
And the airway. So he also has an ABC problem. So you check mark. Okay. Yeah. So looking at an airway problem with an actual problem gives him the edge for me to what? Salute it. That, oh, the little resources I have as a nurse manager, I will give you. That has a sleeping problem. Somebody said psychological. Okay, so Maslow. This guy is awaiting physical therapy. Where will this guy go? He's awaiting. He's stable.
He's stable.
He's stable. He's not telling me that he has any problem. He's just waiting. Even this guy too, he's stable. Because the answer option did not state any problem the guy was having. So this guy is stable. And also, yes, so this one is stable and this one Maslow is stable. Okay. A patient with this guy has what? An actual problem. He has an actual problem. But this chronic thing his case. David, do you understand?
So if I assuming we modify the A with a potential problem, would we have still gone for that answer?
This one,
among all these answers,
at risk
is
okay.
Is at risk of.
So let's analyze. A patient at risk of is having what? At risk of chest pain. So he's still having chest pain in his airway. So he's having still the ABC. He falls under this. But the at risk of making a potential. Okay. Potential. So he's having AP. Okay. This guy has Maslow, but he's stable. The stability makes this a priority over him. A patient awaiting physical therapy, the answer option did not state any problem. So physical therapy, yes, somebody can be on the ward. Physical therapists, physiotherapists, they go everywhere. Okay. Sometimes they even come and help you to walk, do passive exercises and active exercises in bed. Okay. So it's stability. So still, this one will be a priority over this. A patient with, so this one has an actual problem, but the chronic, so stability over instability, it is what? Stable. So still, this one won. You understand?
Okay.
Yes. You, so sir. Please go, and I don't know how you are going to learn and understand this Amasa principle. Go and learn it. Okay. Now let's go. Next question. Question 3.
Sabai, should I go on?
Okay. Okay. Hey, I thought you said you were running away.
Okay. No, my background.
You can't run away.
Somebody broke something, so I had to rush.
Oh, okay, sorry. Amasa,
okay,
shoot.
So, all right, sure. Which patient should the nurse see first? 1, patient with new onset of confusion. 2, patient requesting pain medication. 3, patient upset because family has not visited. D, patient waiting for lunch. So right, this one is the A. Patient with new onset of confusion. Because
with A.
It's A because the wait means it's happening, and the new onset means is happening. It's an actual thing going on, and the confusion is also
something to be worried of.
Yeah, something to do with the brain. I want to remember.
Yes, it will fall under the
something-
stability or instability. They will be unstable.
Unstable, sure. And the one requesting for the pain. Okay, so sorry, please, you can continue.
Continue.
Okay, so the one requesting for pain meds, although it's a physiological problem, it doesn't beat the one with the new onset of confusion.
So this one has a Maslow problem. We all know physiologically.
Yes.
Okay.
Yeah.
Go on.
And then with the C, the patient is upset because his or her family hasn't visited. This is love and belonging.
So Maslow problem. Okay.
Yeah, also has a, but it's not as important as the one with the new onset of confusion. And then the patient waiting for lunch. This is also a physical need. The patient needs food to survive, but he or she can wait for us to see the one with the confusion who has safety issues and all that before we come and see the person. Thank you.
Yes. This one is a
Some people
Maslow
cannot
need.
wait for the food.
It's not diabetic. It's not hypodiabetic. So
this is a physiological need. I'm really waiting for my lunch to be able to get the energy to watch the Black Star match. Why won't you attend to me first?
Some people cannot wait to eat the
you can survive. Man shall not live by bread alone.
Let's continue.
You are not experiencing hyposynthesis.
Yes, who will try? Now Lois is getting the concept. Who will try? Another person. David, you are having doubt. Try. See, you people should be like David. Always David worry. David will make sure he understands before we go. It's not a rush to finish this slide. I can give the slide to you. If you don't understand, you will go and read and you still fumble. Have issues. Yes, Lindsay, your hand is up. You want to try question 4?
Yes,
Amasa.
please.
Okay, shoot.
Okay, so question 4. A nurse received report on 4 patients. Which patient has the highest priority? A post-operative patient with stridor. B, a patient with chronic back pain. C, a patient awaiting discharge. D, a patient requesting a blanket. Okay, so with the Amasa, the option A is an airway problem. The stridor.
Okay, stridor,
is an
upper airway.
problem.
Check mark, okay.
And then the B, a patient with chronic back pain. This one is
You've
a
left something
chronic
with
case.
AO. You've left something with AO.
The patient is unstable. So the patient is unstable and there is an actual problem as well.
Yes. Okay. Let's go on.
Then with the B, it's a chronic issue and the patient is stable as well. And then
Yes,
pain is a
actual
psychological.
problem, but it's a chronic pain. Okay.
Yes, please.
Continue.
Okay. Then with the C, a patient awaiting discharge is also a stable patient. There is no actual or any problem as at now. Then a patient requesting for a blanket. This one too, there is no actual problem. Nothing was actually stated. So I assume the patient is also stable. Just need a blanket. So looking at the
He is
options.
requesting a need. A need. He is requesting a need.
Okay.
So Maslow. Though he doesn't have a problem.
need a need.
Yes. Blanket, whatever she's going to use the blanket for, but she doesn't have a problem.
Yes, sir.
Okay.
Okay, so with the
what
four
would be your answer?
options, so my answer would be option A, a post-operative patient with the stridor. Thank you.
Continue with 6. Nobody will talk. Do it.
Okay,
Amasa.
so with the option 5,
Mm-hmm.
which patient should the nurse see first? A patient with blood glucose of 42 milligram per deciliter and diaphoresis. B, a patient with type 2 diabetes and glucose of 150 milligram per deciliter. C, a patient with chronic kidney disease. Then D, a patient requesting pain medication. Okay, so sir, with the first one, glucose of 42 is hypoglycemia. Anything below 70 is hypoglycemia. So, and then with the diaphoresis, so this patient is unstable and is also having an actual problem. And then there is also an airway problem as well.
Okay. Where is the airway problem?
So there is actual problem, and then hypoglycemia.
Oh, okay, yeah. But it's not an airway problem.
Yes, please.
No.
Okay, continue.
Okay, and then with the option B, a patient with type 2 diabetes and glucose of 150. This one is a normal blood glucose level. Patient is stable.
Where will you fit it here?
So this one is a stable patient.
Mm-hmm.
Option
It has
C.
an actual problem because of the weight.
Okay.
Okay, continue.
And then with option C, a patient with chronic kidney disease is also having an actual problem, but is also stable. And then lastly, with the option D, a patient requesting pain medication is also having a need or requesting for something, but is also stable. So looking at the options, say I'll go for option A, patient with blood glucose of 42 and then diaphoresis. Stable.
This is, you left this one, you said this one is, you were interchanging this and this.
Okay.
This A is acute or chronic. And this is stable or unstable. Okay.
Yes, sir.
So, yes. So this guy, type 2 diabetes, sorry, here, a guy with an actual, the weight is an actual, but the chronic make it what? Will fall under this. So AA. But all the same, the A is correct. Okay. Perfect. A new person, sharp.
Thank you.
Yes, Lindsay has got the concept. Another person. Lindsay, go and shine. Yes, the guys who will shoot for me. Question 6 is the cheapest of all the questions.
Which
Yes. Joanna, you want to talk?
Hello. Okay. Which patient requires immediate assessment?
Okay.
A patient with blood pressure of 80/40 millimeters per mercury and heart rate of 128 beats per minute. B. A patient with chronic atrial fibrillation. C. A patient awaiting discharge. D. A patient with constipation. Okay. I'll pick A.
Analyze.
Okay. So a patient with a blood pressure of 80/40 and with a heart rate of 128. It could be shock.
Okay, so where will you fit it here?
So I will fit it as this could be an acute thing. So the patient and then stable versus unstable. So it's the patient will not be stable.
So
It will not be stable, which is unstable, yeah. So with the B, it's chronic. It says with chronic. So
Okay.
and
It's an actual versus.
Now you let her finish, then we.
please let me
we-
finish, baby. Why, Mister?
Yeah,
So a
King David,
patient
let
with
him
chronic
finish.
atrial fibrillation. So you said chronic, acute versus chronic. So this is chronic. So
Okay.
I will not pick this. So a patient awaiting discharge. This patient is stable. So
Stable.
he doesn't need attention. Like
Mhm.
D, a patient with constipation. So comparing the D with the A, I'll pick the A.
Why?
Constipation. Yes, the patient has constipation though, but the patient is stable. As compared to the A is unstable.
So where would D fall here?
Okay.
Under mastura.
Elimination.
Under mastura hierarchy of needs.
That's problem with
No.
elimination.
Okay, he has problem with elimination. Okay.
Oh, Jojo.
And he has an actual problem. Okay. So Maslow's and an actual problem. But the A is unstable. This question did not say anything, did not describe or went on further to describe anything instability. Okay. So we can't give it to D. We can give it to A. Okay. A patient with, see, when you see the weight, you already have your A. This one, actual. So you get your A down. You write it down. Blood pressure of 40 and heart rate of 120 makes it unstable. Yeah, I mean, it's not difficult. Ayaraga, your hand is up. Joanna, you answer the next question. So be ready.
Okay.
I was asking
Yes,
her,
sir.
I wanted to ask something.
King David,
Okay, Dave.
your hand is
Yes,
not
sir.
up. My hand is up, please.
Let David let
Okay,
Ayaraga
don't.
speak.
My hand is not up. Your hand is not up. Please
Yes,
let
sir.
your hand be up and you share your thought. I just wanted to
I
add
was
to my sister in terms of the A. Indeed, it is A. And if you look at the A critically, a patient that has an OBS, we are using the AMASA. Yes, it's an acute challenge. He has an acute challenge. And then with a low BP, high pulse, which probably indicate a shock, this patient is unstable on the issue. So if you say, if you are looking at even he's unstable, he has an actual problem indeed if you are using the AMASA. So so he's unstable, he has an actual problem.
Did you say he has a Maslow?
He has an
Did you mention ma?
actual problem, not a potential problem, because
why did you say he has acute problem?
see, I didn't get
Look at
you, sir.
What makes this sentence acute? Let's leave physiology. Let's leave science. Let's analyze English.
Boss,
This
the weight.
full sentence.
With a blood pressure.
The
Does
blood
that make
pressure
it
of 80/40 makes
Does
it
that make
actual.
it an acute problem? Remember, the AMASA, we have acute over chronic. So where is the acute here? Because Ayaraga
For me,
says he can
actual.
see acute.
No, it's actual problem. It's not not something
Please,
that is
does
solving
somebody
it.
understand what I'm saying?
Yes,
Okay, let me
yes. Now I
analyze it.
get you,
Okay.
because
So it
indeed
didn't say
his
whether
weight.
it's a new onset or
Yes,
Yeah,
it did
carry
not
on.
say a new onset or suddenly.
Yeah,
Or
yeah,
not use those English describers. So you can't
yes.
choose the acute. You can't go to that bundle and choose acute or chronic for it. Please, you understand? Understand this thing. Oh. I don't know if I should boycott today's class so that we go over this
I
prioritization
think
again.
he doesn't have an acute problem. He doesn't have an acute problem. He actually has
Please go over
an
again.
actual problem, and then instability. He's unstable. Those are the main things that he has because of the tendency of developing the shock. So it is actual problem which is there with, and it's unstable because of the vitals. Indeed, there's no acute nature on it. Yeah.
In any acute, I feel there is always a sign of onset. There is like a sentence that we go with onset of, which is acute, sudden. But in this scenario, I think it's just actual problem, not acute.
Yes, and instability. I thank God you guys are understanding. David, I saw your hand up. You drop it, or you don't want
Yes,
to talk
sir.
again. Let's go to 7.
No, I'll
Okay.
talk.
So which client should the nurse see first?
Oh,
A
okay.
patient at risk for fall. B, a patient with active bleeding, a GI bleeding. C, a patient at risk for infection. D, a patient concerned about body image. So with the A, so considering the actual versus the potential problem, this is a potential problem. And then the B, a patient with active GI bleeding. So I would pick this, like the B, because the thing is occurring, the bleeding is occurring.
So where does it fall here? That is what I want to hear.
Yeah, okay.
It falls under airway.
No, don't answer. Let her do it.
Okay.
Because
Okay.
Joanna, I want to push Joanna to understand before we move on. If she doesn't understand, she will answer all the questions. Yes, link. You should be able to link it. Mhm. Yes, will you hire a lawyer? Victor, your hand is up.
Hire me, let me rescue you.
Yeah, it's
Okay.
Victor, but I can also talk.
Okay,
Victor,
is this
I can talk.
with stable
Okay,
versus
someone is talking.
unstable? Like, so this the client is unstable, right? This client is unstable, like with the active GI bleeding.
Okay, somebody should help. Yes, unstable.
Yeah.
What
Yes, we
again?
can say it's unstable. At the same time, it also falls under circulation.
And
Circulation
then I
problem.
think it's an acute thing too, because
No,
the bleeding is occurring.
There is
Okay,
no
it's not a
acute
new
in
onset, right?
yes, there
He's
is no
having an
acute.
Aaron
actual problem.
Oluku,
Actual
Oluku,
yes.
there are some hands up. Please, let's raise our hands and be attended to. Please. There's some hands up, please.
Yes, Victor, your hand is up.
So actually, it's victory, but let me talk also. It's victory, but with this one, the master was GI bleeding, circulation, and then the client is also unstable, and then the client is also having an actual problem. Yes.
This guy has
And even with the circulation, if with the circulation you don't attend, it might affect the airway, where we're going to lose the RBC and then other vitals, and then hypovolemic shock and these things. Yes.
Don't worry. Don't think for the answer.
Okay.
So that is what you said. So this guy has an this when you take this bundle, he has a problem here. What is his problem? His problem is circulation. So we check mark for the A. Okay, weight has an actual problem. So we check for this. And the active bleeding, okay, the eye bleeding makes him unstable. That's it. So he has 3 problems. Joanna is able to show us the answer, but she's not able to explain why she got the answer right. That is why I want to push her.
Okay, so
Okay. Okay. Will you continue, Joanna?
Sir, please, you said that B is a please, you said it's a circulation problem.
Yes. Because
Okay,
of this
thank
English.
you.
Okay. Yes, Delali, I saw your hand up. Do you want to add something?
I think you said the three is okay. The patient has
Perfect.
is unstable because of the GI bleeding, active GI bleeding. Then because of the word weight, is having bleeding, makes it an actual patient. Then
Yes.
the circulation too, because of the bleeding, so it falls under ABC.
Yes. So
So the
the
C
is a potential.
arterial potential. Okay.
And the patient concerned about body image. Where would this guy fall?
Muscle.
Maslow.
Self-esteem.
Which part of
Self-esteem.
Self-esteem.
self-esteem, actually? Okay. You see, when you grab it like this, remove. Number 8. Mm-hmm.
Sir, please, I
Victor.
want to try.
Okay. But Victory's hand is up. Oh,
Yes, I'm the one speaking.
okay. Hey. Okay, talk.
Now I want to try. Okay, so question 8. The nurse receives the nurse receives reports on 4 clients. Which client should be assessed first? A. Patient who has not voided for 10 hours. B. Patient upset about hair loss from chemotherapy. C. Patient anxious about surgery tomorrow. D. Patient whose spouse has not visited.
All right.
Hmm.
Shoot.
So let
Let's
me
go.
start with the elimination.
Uh-huh.
So with the patient upset about hair loss, no yeah, self-esteem.
Speak English. Oh,
Oh,
hello.
sorry, self-esteem.
Self-esteem. So that
Mm-hmm.
is Maslow, right?
Yes, please.
And self-esteem.
And
Okay.
yes, please. I also eliminate the D because the patient is stable. Patient whose spouse has not visited. Stable.
Stable. Okay. And what?
And yes, sir, please, that's what I know. Maybe I'll get some
Cool.
lawyers along the way.
Let's go.
All right. So patient anxious about surgery tomorrow. Ish. And patient who has not voided for 10 hours. So with the A, I think the patient is unstable.
Okay.
Yeah,
Unstable.
Yes. Yes, please.
elimination, masculine.
Okay.
Maslow.
But
He
I'll go
said
for the
elimination.
yes, please.
Elimination will fall under which part of Maslow's hierarchy?
Physiological.
So is it physiological?
Okay. Right. So physiological here. How about this one?
I think that one
Patient
is
is
knowledge
anxious.
deficit.
Anxious about surgery tomorrow. Yes. Anxious. He has a problem.
Yes, unstable.
Okay. You see unstable.
Safety, right? Safety.
Okay.
Yeah.
Even if you want to use
Willingness.
and safety.
Okay.
Unstable safety, unstable elimination. So unstable safety is here. Safety is here. On the second, no, okay.
Yeah.
And so this guy is unstable, he's here. This guy is unstable, he's on the first. So this guy wins.
Okay,
You
I now
understand?
understand. Thank you. Yes.
Yes, they all fall under the Maslow, but one is having a basic need, one is having a safety need. Okay.
Thank you, sir.
Yes. So, you know, the AMASA is just the first letters we have chosen. But you, as an individual, yesterday we learned, you should go inside and learn, okay, what goes on with the A? I have an airway, I have a breathing, I have a circulation. Okay, so you should know that physiology there. Otherwise, you'll get some questions that will harm you. Okay, Victory, shoot, number 9. When did you join this page? Because we used to have Victor. Today we are having Victory.
I think I joined not less than 2 weeks ago, no longer ago.
Oh, okay. That's why I was calling you Victor. Okay, shoot. See, I know everyone. Okay, shoot, number 9.
Please, it was Victory that read, though. So should Victor read or Victory read again?
No, read and answer. And Eunice will answer question 10.
Okay.
Then remove.
Question 9. Which patient should a nurse assess first? 1. A stable postoperative patient on postoperative day 2. B. A patient with sudden shortness of breath after surgery. C. A patient requesting pain medication. D. A patient waiting for discharge. So with the elimination, D. The patient is stable. Patient is stable with D.
D. Did you say D or B?
D for dog. D, please.
D. Oh, okay. So you choose stable for you. What you say is what I'll write. Okay.
Yeah. And with the C, patients requesting pain medication. I'll come back to that. With the 1, the patient who is stable, because they've already said it. The A, sorry. Patient is stable.
Okay, stable. Okay.
Yes. And with the B, patient is unstable and also has an airway problem.
No, so it's acute.
Acute. Yes.
Sudden.
And what else? Unstable
with
an actual. He's got 4 issues on these bundles. I wish I was going to write English and also pass like you. Yeah. So that is it. Okay. Okay. Eunice, last question for you. Thank you very much. Eunice, your hand was up.
Please, yes, please. So number 10, the nurse receives reports on 4 clients. Which client should be seen first? So please, with A, client with chronic COPD requesting a breathing treatment. And then B, client with new onset left-sided weakness and clear speech. Please C, client with rheumatoid arthritis pain. And then please D, client upset because family members have not visited. So please, using the AMASA, with A, patient has acute problem, which is chronic. And then with B, patient has a new onset, so which is an acute problem. And then airway, an acute problem with left-sided weakness and then clear speech. There is airway, clear speech, so ABC also is there and is unstable as well. And then with C, clients with rheumatoid arthritis pain with its actual problem, but it's a chronic issue. And then with B, clients upset because family members have not visited also have Maslow love and belonging. So please, I'll go for B. I'll choose the B.
Your hand is up. Do you want to add anything?
Thank you.
You said A has acute. I don't see the acute here.
I'm talking about actual problem, and then with
actual.
chronic,
okay,
and then
okay.
with chronic as well. Thank you.
Requesting a breathing treatment. You left something here. Requesting a breathing treatment.
So ABC, airway.
A breathing treatment.
A need.
Breathing treatment. I am requesting a breathing treatment. I am requesting a need. What type of need? And the Maslow. Yes.
Physiological.
It's physiological.
Where have you been? Physiological. Okay. Yeah, so B1. Okay. This guy is unstable. Okay. Client with new onset. Oh my God. Left-sided weakness and slur speed. This is purely physiological issues. Okay. With actual, and that's it. Move, making unstable. Thank you so much. So I've not answered it. I've left all the questions unanswered. When you get the slide today, let's shoot. So in the next 2 hours, we have a match. So let's use 2 hours to clear this one. There we go. We have model 6. Model 6 talks about informed consent. We did informed consent yesterday, so we know what it entails. It's a process in which a patient voluntarily agrees to a medical procedure after receiving adequate information. Okay. So the health worker or the doctor or prescriber or provider, not a nurse, is supposed to provide the information about the procedure, the risks, the benefits, the alternatives, and the consequences of refusal. All these things the doctor that's supposed to do. The nurse is not your job. So don't go. Yours is to verify if the patient has received all this information. Okay. So 4 requirements we are looking at. The patient should be competent, psychologically capable of making their own decisions. Okay. An adult who is an alert and oriented patient. Once a patient's nervous system gets involved, confused, if you are confused, you are lacking capacity, you are lacking mental capacity, so you can't make decisions. Okay. That is why some people will give some people alcohol to drink and do some things with them. Later, they will take them to court. Yes, it is not a consensual activity. Unconscious patients cannot consent for him or herself. So, as a nurse, don't accept it. Okay. The patient received adequate information. So, we got all these ones here. Act voluntarily, not under pressure, no coerced, or not under duress. Okay. So somebody and the husband is divorced and they went to court. And they asked them that, they asked the husband that why is it that you said in church that till death do us apart. So why are you divorcing your wife? Okay. The man said that it is the pastor who said he should repeat after him in church. So the pastor was reading a book and till death do us apart, and it is answered till death do us apart. Yes. So that is when you go to court, that thing that the pastors have been doing, we call it duress. They acted under duress. Yes, somebody can go to court and say, it is the pastor who said it. And I repeated after him. So we call it under duress. So consent should not be under duress. It should not be coerced by force. It should be voluntary. Okay. Then able to communicate a choice is very important. Must be able to sign or verbally communicate agreements. That is important here. Okay. So who obtains the consent is the physician or the provider. Because this is is legally responsible for obtaining informed consent. The nurse does not obtain informed consent. Take note. So, provider, you are supposed to explain the nature of the procedure you are going to give. Okay. The risks involved, the benefits that comes with it. Yes, the risks. Yes, this procedure we are going to do, you will bleed. There is a potential that you will bleed. There is a potential that you die. It's 50-50. Okay. You still want us to go? Yes. Okay. There is a potential that there can be an organ damage. So take note. And the benefits, the alternatives. You should tell the patient alternatives. Okay. Patient 80 years old and above who has prostate tumor or cancer. Okay. This age and general anesthesia is almost incompatible because most patients, when they receive GA, the medications and all the gases, it can harm them. It can even cause cardiac arrest on the table. Okay. So you explain the alternatives. Instead of going to the theater to do TEP or remove the prostate, can we give you a medication rather to suppress the growth of the prostate gland? Yes, it will suppress it, but it will not cure it. That means you are going to live with it till you die. But now you have two choices of death. One that is likely to occur now on the theater table, and one that will take long to occur with taking of medications. Which one do you like? So alternatives have been explained to the patient. The patient will choose that, oh, I want the medication type. So okay, cool. Someone will say, okay, I want to risk it. Let's go to theater. Take out 50-50. If you die, fine. If I don't die, we move. Okay. The consequences of refusal. Patient has refused. So a pregnant woman is going to give birth. As the baby is coming, now the baby is locked. Baby cannot come out again. Okay. So CPD, cephalopelvic disproportion. Okay. Baby is asphyxiating. The heart rate is dropping. We need to do an emergency CS to bring the baby out. The pregnant woman says that until the husband comes, she cannot go to theater. Okay. We call the husband. The husband said that he is living, he is in the village. Okay. He just returned from the farm and he's waiting for a bike, an Okada man, to come and pick him to travel from the village to the town, which will take more than 2 hours. Can this baby survive here? And the pregnant woman is saying, no, until my husband comes, I'm not going to do it. Okay. So you explain the consequence of refusal to the patient. If untreated, infection may occur. If untreated, you can die or you can lose your baby. We've done our part, then you sign. The only nurse's responsibility, the nurse plays an important role, but does not obtain informed consent. Very important. The nurse cannot, and the nurse should verify the patient's identity. Okay. So I told you that somebody was going to take out the spleen. And later, after the surgery, they realized that the liver has been taken out. Which consent was signed? The nurse who was looking after this patient, did he or she verify the identity, verify the information, verify the consent form, and verify with the patient if patient was, so patient died and the doctor was arrested. Okay, so confirm the correct, the patient signed the form. Then the nurse should witness the signature, very important. Then assess understanding. If patient is confused, surgery cannot go on. Okay. Ensure questions are answered before patient is taken to the theater. Then you do your nurse's documentation appropriately. Consent form signed, provider notified if necessary. Okay. As a nurse, do not explain surgical risk. Obtain consent, coerce patient, sign for patient. Yes. Okay. Don't coerce the patient. Okay. So let's look at possible examples. Patient will ask, what are my chances of dying during the surgery? What should the nurse say? The nurse will notify the surgeon. Why? Why is it that the nurse did not talk? Because the surgeon must provide answer and all the procedural risk questions. Okay. Let's look at situations that required informed consent. Generally, informed consent is required for invasive procedures and treatments involving significant risk. So these two things. Okay. It's not only when we are going to theater that we look for informed consent forms. There are some procedures that involve significant risk. You should seek consent. Okay. The doctor must seek it. So let's look at the surgical procedure or invasive procedures. We can look at appendicectomy, so many examples. Cabbage. We call this cabbage, coronary artery bypass graft. So when you are taking report and they say cabbage, that's the meaning. Hip replacement, cholecystectomy. Okay. Invasive procedures, cardiac catheterization. Yes. Somebody's coronary artery is blocked or whatever, any cardiovascular issues. Bronchoscopy, colonoscopy, endoscopy, liver biopsy. You should take note of that. Blood transfusion requires informed consent. Anesthesia requires, that is why they come for what? Anesthetic clinic or anesthetic review before surgery. Okay. So you seek consent for the type of anesthesia you are going to do. Is it a general anesthesia or a local anesthesia? So you seek consent for both of them. Okay. So if it is local, we have two types. No, we have three: subarachnoid block, or any of the local blocks. Okay, that are the plexus and those nerve blocks. Okay, so you seek consent. Therapy. You can't just get up and start giving somebody chemotherapy treatment. They need consent. Because when we were reading our questions, some people were concerned that I'm losing my hair, I'm getting alopecia, I'm getting this. Okay. Clinical research. Those of you who are schooling, master's, diploma, degree, you need research, you need consent from participants. This is a non-invasive activity. Participation requires what? Informed consent. That's why the school you are attending, they have institutional board, research institutional boards, okay, or ethics committee. In Ghana, we call it ethics committee. So they will first read your proposal. Every researcher, you first have to write a proposal, like you are going to toast a woman. Then you take the proposal to the ethics committee, and the ethics committee will go through, they will read it, they will know your methodology, okay? They will know your target population or your participants, their age, their sex, okay, their vulnerability, they will know, and your research topic. Forget about plagiarism, that will come later. After that, they want to make sure that the research you say you are going to do is not going to cause any harm in the society. Okay. So the research committee, after they check mark all these things, they will now write a letter to you that per ethics, you are cleared to start your research. Then before they even allow you to go out and collect your data. Okay. Organ donation requires consent. Take notes. Then procedures that usually not requiring written consent. Blood pressure measurement. Routine medication administration. You can't take us to court because you always take hypertensive medication. You saw a new nurse and the new nurse gave you hypertensive medication. You are angry. Is that not the medication you always take? Physical assessment from head to toe. You don't need written consent, but you need verbal consent. Okay, a man going to do physical assessment from head to toe. So there are some countries, men will take care of men and women will take care of women. Okay, yes. So that is it. Routine IV insertions. It varies by facility per facility. So the nurse manager should know all these things and the policies around it. Minors and consent. So generally, parent or legal guidance, they sign this consent. So example, a child coming for surgery, a pediatric coming for procedures. Let's look at exceptions. Some states allow minors to consent for pregnancy care, STI treatment, substance abuse treatment, and mental health treatments. Okay, let's look at an example. A 10-year-old requires surgery. Who signs the consent? It can be parents or legal guidance. Okay. Now, let's shift our focus to emergencies or implied consent. This consent is assumed when immediate treatment is necessary to preserve life or prevent serious harm. Let me highlight it for you. Yes. So a client coming unstable to consent or immediate treatment needed, the doctor can stand in and we do the procedure. We call that one implied consent. So examples, an unconscious trauma patient. So an MVA or motor vehicle accident victim arrives unconscious. We need to act on the patient. Emergency surgery needed or treatment procedures under implied consent. Cardiac arrest. Patient collapses without DNR order. Okay. So last week when I was driving in traffic, the traffic went to red. Okay. Then it's about 4 lanes. So everybody is in their lane in New York. Traffic is green. Everybody is going. One man is still standing there, not knowing he has collapsed behind the steer. Yes, so we have to quickly do resuscitation for him. Okay. Yes, so we call the police, call the ambulance, call fire service. We blocked the road. Then he was fine. He came back to life, and we took him to the ER for continuity of care. Okay. Cardiac arrest. Okay, I don't need you to give me consent before I start my CPR. Okay. Then CPR begins immediately. Patient collapse. Patient has, you don't know whether the patient has a do not resuscitate order or not. You don't know. If you don't know, you have to do CPR. You are a new nurse. Posted to a new hospital. You don't know all the patients, especially those who have been going to care home. Me, it has happened to me before. I went to one care home to work. My first day of working, they handed over to me night nurse. So I was doing my medication. When I got to one patient's room, he was dead long time. I don't know whether the nurses saw it and they intentionally said that, oh, let us hand over to Paul to come and do the last office or whatever. I don't know. So when I went, the patient was dead. Okay. I went to check on the system to see if he has this thing, DNAR form in UK, DNAR. I did not see. So me, I did for him. Okay. Not knowing he has DNR form. But the system, it wasn't recorded. The person who admitted the patient did not record it. So if it was you, what will you do? I call ambulance, I call police. Because this is a coronary case, so it must be investigated. I call police. Police came, they did all their investigations to see, they inspected the body to see if there is any abuse. Maybe somebody has given any medication or done something to the patient. It was cleared, nothing was done. Okay. Then ambulance also came and did the analysis. And we called the nurse practitioner. Mostly in care homes, nurse practitioner, because in the night you not meet doctors. So out of service, nurse practitioners, they will come and confirm death. And we took it was in the morning, and the manager came and brought the CPR form. Well, you see, that's it. Severe bleeding. Patient is unconscious and bleeding. I need to save life. Emergency treatment proceeds. Okay. So the key thing we have to look at is for life-saving treatment should not be delayed. Should not be delayed. When consent cannot be obtained and delay threatens life, implied consent applies. That's it. Why? When does implied consent does not apply? Patient is alert, competent, able to decide. They said we don't want it. Stop. So these are the examples we are looking at. A patient is awake and refuses surgery. The healthcare team cannot force treatment on the patient. Then refusal of consent. Patient may refuse any procedure. Okay. For surgery, blood transfusion, chemotherapy, dialysis, they can refuse. There's nothing you can do about it. What the nurse must do is to respect the decision, notify provider, and document. Okay. So a Jehovah Witness refuses blood products or refuses what blood products, you have to respect it, notify the physician, and document it. Okay. We also did advance directive yesterday. So let's just rush through, then we go. So we are going to look at the living wills, the power of attorney, the DNR, and the pause form. And a lot of people have not heard this before. Today I'll show you. Okay. So these are the objectives. An advance directive. Okay. Victor, this is Victor. Okay. This is 2026. 2030, nobody has seen it before. Even tomorrow, nobody has seen tomorrow before. Okay, right. But today, Victor is healthy. He is strong. He is energetic. Victor can make a legal document through the court, through the hospital, or whatever. That tomorrow, if I become incapacitated, this is how you should bath me. This is how you should feed me. These are the things I want. This is what I don't want. In that case, we will say Victor has made an advance direction. He has given an advance directive on how he or he should be treated or he should be catered for. Victor can say, I don't want you, if I become unconscious, yes, you are thinking about feeding me. Only feed me through NG tube. I don't want any feeding through peg tube or whatever. I don't want it. Okay. You don't have to resuscitate me because I have so and so conditions. I don't want you to bring me back to life. Don't stress yourself. Let me die peacefully and go. So all these things are advanced directives. The patient who has walked to your chamber or your bay as a nurse, what advanced directive is the patient having? It is the duty of the nurse to ask the patient, okay, that do you have any advanced directive? And explain to the patient. This one you need to explain. Some of them, when you mention advanced directive, they don't understand. Okay. Yes. So these are the types we have. Okay. Sometimes the patient will not make it, but the doctor will make it. Okay. So we have a living will, which I explained today. This is a legal document. As for will, it's very common. But in Africa, people make will only when we hear will in Africa, people are only thinking about I have 4 acres land here. I have a mansion here. I have bought this house here. That is what people are. No. A living will is a legal document that specifies the type of medical treatment the person wishes to receive or refuse if they become terminally ill or incapacitated, in addition to the one we know. Okay. So what are some of the will? I can make a will that when I go mad or when I become terminally ill, okay, don't try mechanical ventilation on me. I do not want to be placed on a ventilator. I don't want any artificial feeding. No. I do not want you to tube feed me. No NG tube, no peg, nothing. Okay. I don't want dialysis if I lose my kidney. I don't want it. Don't resuscitate me if I collapse or get cardiac arrest. Okay. don't hydrate me through IV fluid. If I'm dying, let me die. So a patient with advanced cancer states, if I become unconscious, I do not want life support. Yes, those of you who manage cancer patients, you hear most of these statements. Okay, because I've told you that the death of cancer patients is just like today. They will be very active. Close from work, go home and come back the following morning, they are dead. They die. So people will be like, let's resuscitate this patient. Most cancer patients will say, no. If I become unconscious, I don't want life support. This preference may be documented in a living will. Okay. So characteristics. A living will should be documented. It's a written document. It takes effect when the patient cannot communicate. Understand this? Yes, cancer patient has made the decision and has a living will. But now, cancer patient is unstable, but he can talk. Okay, you still have to ask, please, can we give you blood? He will say, yes, give me. But in the form, he says no. So you need a witness for him saying yes, and you need a documentation, document it down and mention the name of your witness in your documentation, and also mention in it that you have informed your nurse in charge. Okay. And guides healthcare decisions and also support patients' autonomy. Yes. So living will is what treatment the patient wants to refuse or wants. Okay. So example, a patient's living will state he does not want mechanical ventilation. The patient becomes unconscious and develops respiratory failure. What should the nurse do? Does the nurse know that there is a will? That's the first question we should ask. Okay. The nurse will go and ring the emergency buzzer or call bell. The patient is getting respiratory failure. Then his colleagues will come and laugh at her or him that you don't even know your patient. Don't you know that this patient has a will? Okay. Yes. So the nurse should honor the patient's wishes and notify the healthcare provider. Okay. Let's look at power of attorney. Yes, I have made a will, but sometimes I will not make a will. Okay. I will just appoint one person that, hey, instead of stressing myself to make a will, in future, when I become incapacitated, I have rather appointed Victor to be in charge of any decision about my health, and Victory in charge of any decision about my finance. So I will tell Victory that some of them tell their POAs that, oh, I have so and so in this bank account. In case I am dying, you can take some, or I have given you the power. Not even can. I have given you the power. Then both of them will go and make a legal document in court. So Victory will bring the legal document to the hospital. I have the power of attorney to what? Yes. When you come to abroad, you see a lot. Yes. Okay. So mostly people with power of attorney to finance, most of them later their mind changes, especially when you go to care homes. They know that care home, you are going to die. So when we call them that, oh, your family member needs this, they will say, See, don't worry yourself, okay? If the person dies, all the money is for the power of attorney. So, the one holding the POA. So people call it healthcare proxy, healthcare agent, medical power of attorney. Yes. You can appoint your spouse. You can appoint your child. You can appoint your friend. You can appoint a relative. I have seen somebody who has appointed a niece, though she has children. One of my patients. And he said, no, I prefer my niece to be the power of attorney of my finance. What can you do? Who appoint me as power of attorney for finance? Victor, Victor, if you are, in case you get, in future, when you get plenty money, you can use me as your power of attorney. Okay. Okay. So Mrs. Brown or Mr. Brown appoints his wife to make healthcare decisions. If he becomes unconscious, his wife automatically becomes healthcare proxy. Okay, healthcare proxy. Wow. Okay. The responsibility of Mrs. Brown's wife is to make decisions for surgery, blood transfusion, dialysis, or healthcare. Okay, some people can divide it that you, this person, I want you to take care of my health, make decisions for my health. You to make decisions for mine. Some two will combine and give all to one person, and it's your life. Okay, so the patient make decision as long as they are competent. And the healthcare proxy only assumes authority when the patient loses decision-making capacity. You can't go and make decision for somebody who is alert, conscious, able to make no. Okay. So a patient with dementia becomes unable to communicate. The designated power of attorney or healthcare proxy makes decision. That's it. Life goes on. Okay. So that's the key pearl. So if you want to know the difference between a living will and a power of attorney, take notes. As you grow, as you get money, do one for yourself. Either you make a will, you and your lawyer go to court, you write everything down in the will, or you go to court and choose people that, hey, I don't have the stress of going to write so and so down. Anything about my money or my health care, I give it to this person. I give it to my children or whatever to take care of. My sister, my brother, my wife, my husband. Okay. So women, when you get money in future and something happens, use your husbands as your power of attorney. Okay. I know people will be complaining backstage. Okay, a patient says, I don't want a ventilator. This is a living will. Okay. Another patient says, my daughter should make decisions if I cannot. This is the power of attorney. Now let's go to another aspect of what? Advanced directive. We call it do not resuscitate. Okay. And DNR or DNAR, whichever way you see it. Orders is a provider's order directing healthcare personnel not to initiate CPR if the patient experiences cardiac or respiratory arrest, cardiopulmonary arrest. Okay, good. So DNR does not mean DNR means no chest compression. If you want to understand this, look at CPR. What goes into CPR? In CPR, you do your chest compressions. You definitely should stop the heart. So it's called defibrillating. Okay. You definitely say, oh, let us secure the airway because we are doing CPR. Intubation fork. That is why I've highlighted it. Intubation fork. So in US, they'll say DNI. Somebody has DNR, and they will specifically state that DNI, do not intubate. Okay. Then emergency medications during cardiac arrest, the vitamin, adrenaline, whatever, all those medication, ACLS. Don't try. Anything to reverse this cardiac arrest, don't try. Allow me to die. I don't want stress. Okay. Okay. Let's look at the other side of DNR. Lindy has made a DNR order. Lindy is alive today. Lindy has no cardiac arrest. Okay. So if Lindy needs oxygen, we will give. If Lindy needs antibiotics, we will give. If Lindy needs pain meds, IV fluids, we will give. Okay. If Lindy needs cardioversion for a stubborn atrial fibrillation, we will give, because she has not had any arrest. If Lindy needs tube feeding, we will give. Lindy is playing, got a wound, we will care for it. Lindy is end of life, she is aging, she is dying, comfort care. Okay, we will give. So we will give her, so Lindy gets cardiac arrests and the EKG becomes a flat line. Then we will say stop. That's it. So a DNR patient develops what? Pneumonia. The nurse should what? Administer prescribed antibiotics. Pneumonia does not mean cardiac arrest. Okay. A DNR patient complains of pain. We will provide what? Pain meds. Because pain does not mean cardiac arrest. So DNR only becomes active during cardiac arrest. That is it. Before cardiac arrest, give everything, provide all treatment. During cardiac arrest, nothing, CPR, nothing, no. Okay, so that's it. The examples explain all this. Now let's go to we call it the paused forms of physician orders, is an acronym. Physician orders for life-sustaining treatment. Life-sustaining treatment. The physician, the doctor has made orders for orders of treatment that will sustain somebody's life. Okay. This is a medical order. It is not a legal order. It is a medical order completed by the doctor or the provider that outlines a patient's wishes regarding life-sustaining treatments. Okay. Yes. What is the purpose? It translates the patient's preferences into actionable medical orders. So, my friend is Lindy. Lindy is a medical doctor. I can tell whilst I'm alive on the ward as a patient, I can tell Lindy that, see, if I become unconscious, if I become vegetable, this is what I want. Okay. I made my preferences to the doctor. And the doctor, yes, doctor came back in the morning and I was having this unconsciousness. The doctor will write the orders down. Let's give him this, let's give him this, let's give him this. We call that one paused. Okay. No, mercy killing is euthanasia. Euthanasia, DNR. DNR is not mercy killing. Okay. I'll explain that to you. So we usually use the paused for what? Terminal illness, advanced chronic disease, frail elderly patient, and hospice patients. So the doctor will make the orders down. Okay. ENR sometimes covers CPR, attempt resuscitations or not. Okay. Intubation, it is the preference the doctor is writing. That is it. I have made my preferences to the doctor. Doctor is writing it in my folder for nurses, other doctors, other nutritionists, physiotherapists. Everybody should do for me. That is what we call posts. Okay. So the doctor will write, intubate this patient, put this patient on mechanical ventilator. Okay. Feed patient or don't feed. The doctor is acting on my preferences. Give antibiotics, whatever, or withhold. Transfer patient to this hospital or retain at home. That is it. So in care homes, some of the patients, they will say that in case I become so and so, they will specify and state the reason that in case in UK they call it EHCP, Emergency Health Care Plan. Okay, yes. So in case I become so and so, I'm a care home resident, I have this condition. Yes, I have. It has been on me for so many years. So it's a waste of time to take me to hospital. Let me remain at home. Okay. Yeah. So when in the morning as a night nurse, I know a lot of you like money. So they will say that even when you come here and you are recruited to hospital, you now pass one corner, go and enter in care home and do local. Okay. You will meet all these scenarios. Night nurse, you went to work, you were there, the carers will come and call you. This patient, the temperature is too hot. The patient is becoming confused. He's getting infection. He's getting so and so. Okay, he's becoming aggressive. Sudden change on instability. Care home is not hospital. You have to take the patient to hospital. But the advanced care plan says when the patient has a urinary infection, we should rather call a doctor for the doctor to prescribe antibiotics instead of taking the patient to hospital. I mean, so you should read all these things to protect you. Okay, you can't just enter. It is care for hospital. People will easily come to your aid, but for care home, sometimes the nurse, you are alone. You are the only nurse on the floor with healthcare assistants and LPNs. Okay, so you make decision. You are everything. You are a manager, you are whatever. So, but you get your money. Yeah. So let's look at the difference between advanced directives and post forms. So advanced directive, you need to go to court to get it, or it's a lawyer will prepare it for you. It's a legal document. But post is just a medical order from the doctor. Advanced directive tells us the future wishes. But pause is what? Current treatment orders. This one is signed by the patient, but pause is signed by the doctor. An advanced directive applies when patient cannot make decisions for themselves or mentally incapable. But pause applies immediately. I can be fit now and still tell my doctor to prepare me what? A pause form. Okay. Yes. So that is it. Do one for yourself. So nurses' responsibilities. you always assess the presence of advance directives. Never treat any patient, especially if you are the nurse doing what? The admission. Assess and help your colleague nurses. Some of the nurses, they will not ask, they will forget. Okay. So ask, do you have a living will or a healthcare process or advance directive? Then you document the information you got from the patient. Record advance directives in the medical record. Serve as an advocate, as you all have always been doing. Okay. Educate family members, clarify their misconceptions, and notify the doctor if any conflict arises. Okay. If family comes tomorrow and say that, yes, we were not there when this guy made these orders, I mean, patient's wishes takes priority. So today you have done priority. So you should know how to manage your cases. Okay. So a patient's living will states no ventilator. Family insists on intubation. What should the nurse do? The nurse has something we call ethical dilemma or professional dilemma. The nurse doesn't know what to do. Okay. This is what the nurse should do. The next one, you are an advocate for the wishes of the patient and also notify the provider. Okay. You can also tell your boss. Okay. Now, let's look at Self-Determination Act. Healthcare facilities must inform patients about advance directives. Okay. Ask whether they have one. Document their preferences. It's an act, it's a law. So, Patient Self-Determination Act is a law. So every hospital must make sure you inform patients. You are not the one to tell them whether to do or not, but your own is to tell them that there is something called advance directive. Okay, this is the ups and this is the downs of it. You wish to do, if they say yes, you do it. If they say no, I mean, ask whether they have one, document their preferences, and respect their decisions. So in future, when anything happens and we go to court, they will bring this act. That hospital, you were supposed to inform the patient. Did you? Yes or no? Then we check. If yes, we check. If no, then one crazy lawyer will come and collect over 100,000 or millions of dollars from the hospital. I've told you that some people walk to the hospital because they want to see the hospital, not because they are coming for treatment. So you too, you should be a reader and a learner. Okay. A patient appoints his son to make healthcare decision if he becomes incapacitated. This document is what? Who will answer?
Is power of attorney.
It is a durable
See.
power of attorney.
Power of attorney.
Okay, I will not answer it. When you get it, then you clear it. Let's go. Okay. Question 2. A patient has a DNR order and develops severe pain. What should the nurse do?
Give anti-analgesic.
Provide comfort measures.
Okay.
Provide comfort measures.
Okay.
A.
Provide comfort measures.
Okay. Question 3. A patient's liver will state that she refuses mechanical ventilation. Family members request intubation. What should the nurse do? Ethical dilemma.
Notify provider and advocate for the patient's wishes.
Yes, notify the provider.
Yes. So, teasers. This is all about what? the documents we have running in the hospitals, living will, power of attorney, DNR, post. This is their purposes. The golden rule says that always respect patient's autonomy. The patient's document wishes supersede family's preference, and DNR means no CPR. Okay, so take notes. Let's look at safety and risk. We have 1 hour to live. Okay. Safety and risk reduction. As a nurse manager, you should manage the safety of people in their ward as patients, their families, the nurses working with you, the healthcare assistants, and everyone who enters your unit. Their safety is very important. Falls, restraint, suicide, seizure, fire safety, and what? The pass technique for fire extinguishers. Okay, so let's go down and learn these ones. Okay, so let's take the first one, falls. How can we prevent falls from patients? We put in interventions to protect patients from accidental injury caused by falling. Falls are among the most common causes of injury in hospitalized patients, especially old patients. They will die. Once they get falls, they go to hospital and come back. That's it. They are not going to be strong again. Okay. Always prevent falls. Who are at risk for falls? The age above 65 years. The history of previous falls. So you ask them, within the last 6 months, have you had any fall? Are you taking any blood thinners? A patient who has had a fall and is taking blood thinner, you treat the patient as a trauma patient and you do your trauma documentation. So take note. Confused, a patient who is confused or is demented. Someone who is
Hello,
weak.
sir.
Yes.
Please, could you repeat that point again? A patient who had fall should not take something.
Falls and taking blood thinners.
Okay.
You know, blood thinner. All these Eliquis, Apizaban, and
Anticoagulant.
all
Antiplatelet.
anticoagulants.
Okay.
Yes.
Sir,
Or
please, is it
Zaparin.
because
You treat it as a trauma. Why trauma? Because in trauma, you see what? Bleeding, active bleeding. Okay. Active bleeding. When this patient is taking blood thinners and they fall, assuming they hit their head, any other place, the blood vessels there will rupture. And when it ruptures, they don't have that strong ability to clot because they are taking blood thinners. So they will also experience active bleeding. It can be external bleeding or internal bleeding. So when they come, what do you have to do? You have to put them on what? Trauma chart. Maybe trauma 3 or trauma 2 chart. I would tell you that the first 1 hour, you do your 15 minutes, 15, all those vital signs, the trauma checks. Okay. Put them on monitor them. Because if they're having internal bleeding or any occult bleeding inside, and you don't check, they will die. You go and meet them dead in bed. They will bleed and all their blood will finish. And you don't know. Somebody has banged the buttocks on the floor from bed, fell down. Okay, he's taking blood thinners. Do you know the amount of blood vessels in the pelvis? Okay, yeah. So you do your trauma checks, circulation. Okay, circulation is found in trauma care, the ABCD bundle, trauma, exposure. Circulation is here. So a patient who has had a fall and is taking blood thinner, this is where we focus. Take notes. Okay, let's continue. So people who are taking sedative medication, benzodiazepines, opioids, antihypertensives. Okay, yes. People who are visually impaired in your hospital, they are false risk. Put them on false risk. When you are doing your assessment, your initial assessment, the system, the questionnaire will ask you, is there any false risk? Yes. Or is there any risk? Yes. Patient is having a false risk. Okay. Dizziness. People who are having orthostatic hypotension and people who are having unsteady gait, we put them on false precautions. Okay. That is what you should know. So what are the preventive measures? You keep their bed in the lowest. See, this is the word. Lowest position. This reduces injury risk. Some of them, we even put a false mattress beside their bed. Okay. Because there are some patients, when they sleep, they roll, and in the morning you go and find them on the floor. So you put false mattress. That's mattress we use at home. You put one beside each side of the bed so that when they fall, yes, they will fall, but it will reduce the injury, the degree injury. Then their core light system is very important. It should be within reach. Okay, it should be within reach. So that is what you should know. Okay. Then their footwear, it should be non-skid. Have you seen these socks before? You see that white thing under it? It will never let you sleep. Okay. They have false this sensor, we call this sensor mattress. Sensor mattress. Okay. So once they step on it, an alarm will blow to the next station. They know that so and so patient has left the bed. Sometimes to this bed, you can set a bed alarm on it. Okay. So adequate lighting, bed rails should be up 2 side. Mostly 4 side is considered restrained. Okay. Patient, they can talk just that they are weak and other stuffs. Okay. Remove catheter. It prevents tripping. So that's what you should know. Frequent rounding. Every 1 to 2 hours, you go and check on the patient. I've told you the patient is for the nurse. Okay. The healthcare assistants are there to help. That is why the acronym is HELP. So they'll do their hourly checks, but you should go and do. Sometimes you do every 1 to 2 hours. Do it. Go around and check on the patients. How are they doing in bed? Okay. Yes. Bed alarms is very important. You put it on high risk patient. Then assist with ambulation. You can use the gate belt if necessary. I forgot to add a picture to this one. So a confused elderly patient repeatedly attempts to get out of bed. What should the nurse do? Repeatedly attempts to get out of bed. What should the nurse do? the nurse should put a bed alarm, set it. It's a settings on the bed. You just set it, you press bed alarm on. That's it. Even when they change position, the alarm will blow. Okay, it will go off. Then frequent observations and call light within reach or nearby. Yes. So some of the medications that can easily make people fall and people get injuries. Morphine is number one. Lorazepam, diazepam, antihypertensive, sleeping pills, and make people fall. So safety before independence. Okay. We have some patients on the ward too that sometimes we don't have any choice than to restrain them. Some of them will be fighting carers, healthcare assistants, workers, beating them, punching them, doing everything. We put restraint on, medical, physical restraints. Some of them are so confused, especially people who come in, they are aggressive, alcohol, intoxication, and all those stuff, psychotic problems. Okay, some will be confused, getting infection. All of a sudden, their situation has changed. We have no choice to put a restraint. Then you inform the doctor, or you inform the doctor to put a restraint, but make sure there is an order for it. So these are the types. Okay, this is soft limb. All these ones are smittings. Okay, soft limbs, smittings, like the boxes, they are punch. Okay, so we have physical restraints. Yes, so physical restraint, can put it on the mid restraint, the vest. This is a vest. We keep you in bed. You can't get out. Okay. We can also do chemical restraint, giving you medication, haloperidol and lorazepam. But these two medications, when you give to the patient, put the patient on what? On telemetry. Put the patient on monitor. Why? Who can tell me why? Some doctors will give you
It
one.
causes. Okay.
Others will give you the two. Me, when they give patients these two, I love it. Yes. Who can tell
Sir,
me?
respiratory depression.
Yes. Respiratory depression. Okay. Yes. Respiratory depression. Respiratory depression. Okay. So principles of restraint use. You can't just go and put somebody on restraint. You should follow principles. One, it should be the last resort. It should be the last resort. Only use after less restrictive measures fail. Okay. We have alternatives. So if you try all these alternatives and it fails, then okay. Reorientation, family presence, diversional activity, depending on the patient, because some patient too doesn't want to see their family. So are you still going to bring the family? No. But this is a generalized or a general alternative to restraint. Diversional activities, bed alarms, pain control, toileting schedule. Okay, yes. But before you put in restraint, the doctor must what? Provide an order. Should provide an order. So the doctor in the order, there should be reason why the restraint is being put on. Patient is being aggressive or interfering with what? Medical devices. Patient who is intubated and unconscious, you need to put them on restraint. Because once they open their eyes and they see tube machines all over, they will remove it and they can die. So put them. The reason why we put you on restraint is because you are interfering with medical devices. You are trying to pull out your IVs, central lines, and all these things. Okay. Then the type of restraint, is it a physical restraint or a medical restraint? And the duration, okay, when the restraint was put on. And the nurse must assess the restraint every 24 hours. But in between the 24 hours, every 2 to 4 hours, the nurse must go and check under the restraint that am I having good cardiovascular supply? Is the skin integrity okay? The nutrition status, elimination, and range of motion. Okay, you can tie somebody's hand and some few hours, the person cannot even do this. You are blocking arterial supply. So you need to remove the restraint. So every 2, 4 hours. Some do 2. Some do 4 hours. Okay. Document. Anytime you go to inspect the restraint, document. Okay. Document. Then maybe you went on morning shift. You did your 24-hour assessment. Then you realize that the patient does not need the restraint again. Patient is compliant. You just take it off. Then you inform the doctor. Then you document. And you also document the reason why you've taken it off. Okay. Then you close the care plan. Restraint should have a care plan. Take note. Everything you do for patients should have a care plan. It should have a care plan. Restraint should have a care plan. Okay. If you set up IV line, draw a care plan for IV line and review it. So a confused patient pulls out IV lines. What should we do? The first nursing action is to try the less restrictive interventions first before restraint. Restraint will always be the last option. Now let's enter into suicide. Okay.
Sir.
Suicide, yes.
Yes, sir. Please, may I know some of the non-restrictive measures?
Yeah, maybe your mind wasn't there. You rearrange, talk to the patient, rearrange. Okay. Family, you can sometimes you can even call their family members when they see them, familiarity. Diversional therapies, watch TV, especially aggressive patients or people who are anxious. Okay. Yes. Bed alarms for people who are trying to get out of bed. Do. And pain control. Person can be in pain, will be very aggressive. Don't just go and put them in restraint. Try to solve their pain issues. Then you schedule toileting schedules. Okay. Yes. So you help them. Or you want to go to the bathroom, I want to do this. You are like, you make that plan with them. Okay. Yes. But when you do all these issues and it still fails, then you put them on restraint.
Okay, thank you.
Let's look at suicide. You know suicide already. We'll go deep into suicide in psychiatry. Okay. So this is a brush up. Suicide, look at the risks. Depression will always be the number one. Major depression. Previous suicidal attempts. Bipolar, schizo, substance abuse, and terminal illness. Okay. Yes. So warning signs that somebody wants to commit suicide. Some patients will be making statements as, I wish I was dead. Everyone will be better without me. I have nothing to live for. This is pure psychiatry. Okay. One, the highest protection for every suicidal patient, whether with a plan or just an idea. Whether it's a plan or just an idea, is to put them on what? One-on-one observation. So in the United States and in abroad, when you can be chatting with somebody, if you make any of these comments, they will call police for you. And once they call police for you, police will take you to the hospital and you will be assessed and evaluated. We call it the psychiatric assessment. Suicide patients are not allowed to go home the day they came to hospital. So bear in mind, while they put suicide, they said Samsung is having suicidal ideas because Samsung said this. You are not coming home. They will take you to rehab. Okay. They will admit you to the mental health unit. Okay. So that is it. I can be joking with you and I will make a statement. See, life is so hard. I wish I even give up. Somewhere you should call the police for that person. That's it. Don't hide suicide, though. Don't hide suicide. Don't hide suicide. Sometimes they bring some of the patients to the ER and they'll be like, somebody had a misunderstanding with the family, the girlfriend. They'll make some comments and the next moment, police in their house. Unless somebody did not hear what you said, they will call police for you. Okay. They call police for you. Okay. So the highest level of protection is one-to-one observation. Every suicidal patient. Okay. The room we will put the suicidal patient in. What should the room be? What are the things we are going to remove from the room? Anything the patient can use to kill himself or harm himself. Belt, you take it away. See, your clothes from head to toe, they will take everything away. And we will give you paper clothes. Paper. You know paper. And we call it paper scrub. I should have added a picture. This paper scrub. That is what the chairs, the monitors, okay, we will close all those chapters. They will remove blades, whatever, IV, cannulas. Once we take your blood, we remove the cannula instantly. Since other patients, you're not supposed to have that one. Okay, we take it off. Glass objects, everything, we take it off. Okay. Suicide rooms don't have a window. It has air conditioning. You know this way you go before the air conditioning. Small holes, central air conditioning. So patient cannot even climb to kill himself. They don't have a window. So that's where we put you at. And the nurse must check all these things and document them. We have a form, suicidal forms. Okay, so anytime they take you, those who be working in ER, when they bring suicide patients fresh, you now see how to, you appreciate what I'm saying. Okay, you should go for the forms. Okay, one-to-one observation. You are not going to do the one-to-one observation. They will definitely get you a seater. Okay, so somebody will be a seater. When you'll be doing one. Never leave the suicide patient alone. So let's say you work in the ER, you have 5 patients. Okay, this patient here is having suicidal ideas. The seater is here doing one-to-one for the patient, and the door should not be closed. Okay, so this guy wants to go for his break. He will come and call you, the nurse. If you are less busy, you can go and sit down. He will go for his 1 hour or 30 minutes break. But what happens to the rest of the patients? So sometimes the nurse, you tell the charge nurse that, hey, this person wants to go for break, or this person wants to go to the bathroom. If this guy wants to go to the bathroom, you are supposed to follow him or her. Okay, everywhere he goes. And we put what we call medical hold. A suicide patient who is brought to the hospital according to the law does not have any right to make decisions for himself or herself. Okay. So the hospital will make decisions for you. We call it medical hold. Okay. So sometimes people who are having drug issues and the police will put a hold on you. Okay. Sometimes the police will stay with you, especially if after your discharge you are going to prison. They will stay with you throughout. Okay. At times too, the doctors will put a medical hold. So once a medical hold is placed on you, you are a goner. People will make decisions for you when to admit you, when to discharge you. You don't have any rights for your life again. Okay. Yes, we want to keep pure 100% one-to-one observation on you. So we will take your blood and all those stuff for the medical clearance, making sure that you don't have any drugs in your blood, you don't have any infection going on. Okay, because all these ones are risk factors that can make somebody have suicidal ideas. Your urine for drugs and all those stuffs. We do your EKGs to make sure the heart, everything is fine. We will also do, then after the doctors clear you medically, we will clear you medically. Then we hand you over to the psychiatric team. And the psychiatric team will evaluate you, okay, and admit you. They will either admit you in the hospital or transfer you to another medical psychiatric facility. Okay, so that is it. So patient says, I plan to overdose tonight. This guy is having two problems. Once you make a plan, I plan. Okay. And one thing I want to tell you, suicide. If a patient says or patient is having suicide issues, there is an idea and there is a plan. Nobody can just wake up and say, I have a plan without first thinking about it. Because in mental health, there is nothing called slip of tongue. Okay. In psychology, we don't have anything we call slip of tongue. Before your mouth speaks, your mind has already thought about it. So for somebody says, I plan to overdose tonight, it means before making this statement, he was having an idea. We call it suicidal ideation. Some of the doctors will write SI. Okay, suicidal ideations. So any patient who comes to your care or your bay or your hospital, if the patient has an ideation, you ask the person, do you have a plan? Be specific. See, we don't do proverbs with suicide patients and major depressive people. We don't do proverbs with them. You go blunt to your words. Do you have any plan? Do you plan to kill yourself? What is your plan? Some will say, I want to take alcohol, I want to take this, I want to overdose, I want to take some people will combine plenty medications and take, and they will come and you have to still do all these stuffs. Okay. So your priority action with this guy, you have a plan. If you plan, then it means there is an idea. So we are going to stay with you one to one. Okay. You notify the doctor, initiate the suicide precaution. So the nurse will always initiate it. Never leave suicide patients alone. Never promise them. You don't have any secrecy with them that you're going to promise them. I'm not going to tell anybody. If they catch you, then they can jail you. So safety always comes first with suicide. And then let's do a seizure. So seizure is another thing that bothers nurses a lot, because when it comes to management, they always fumble. Seizure is just a sign and a symptom. Okay. Seizure is a sign and a symptom. Like somebody has headache, somebody has stomach pain. It's a sign and a symptom. Before you have seizure, are your nerves having issues? That one of the signs is to present as a seizure. Example, a person who is epileptic, a person who has brain injury, the nerves are having issues. And one of the signs, somebody has what? High fever, that the brain cannot control down the fever, the temperature. Seizure as a sign and a symptom. Somebody has electrolyte imbalance, somebody has stroke, somebody has overdosed himself or has taken, is a chronic alcohol abuser and for some time not taking, so he's having withdrawal and is having seizure as a sign and symptom. So seizure is a sign and a symptom. If you get headache, you take paracetamol and it goes. And within 10 minutes, the headache starts coming again. You act on it. So when I see seizure and I act on it, and 10 minutes, 20 minutes, seizure comes again, then it means that that seizure is trying to be stubborn. It's trying to be status. So I must act on it. Okay. Yes. So always take seizure as contraction if you don't want to forget about it. Okay. The maternal or the contraction of the uterus, there should be a start time and there should be a stop time. In between the start and the stop, there should be a duration. You are done. Midwives in the maternity with contraction and their pathograph, they will note the start time. They will note down the stop time and they will note the duration with all their lines. Okay. On the ward, the guy having seizure as a sign and a symptom, you the nurse, whether you're a new graduate or a student, whatever, the start time, the stop time, and the duration. Now, if you are not lucky and the seizure recur or comes again, you also note the start time again and the stop time again. But now, another thing you have to add is what happened, the interval or the refractory interval. The refractory interval. Okay. Yes. So now you have added another chapter to your documentation. But the seizure as a sign and symptom that occurred, yes, it stopped. But within a short time, another seizure occurred. So this was the interval, the time it took. It took 10 minutes for a new seizure to start. Okay. So let's go and learn more about it. We know what are the things that can cause it. Things can cause seizure. A child can be born, and when the child is out, he is having seizure. How was the child delivered? Okay. So many things. It's a sign and a symptom. So once you disrupt the nerves, seizure will set in. So when you see seizure, don't say this, don't discriminate. Okay, that this you are having seizure, you're having this. No, don't do that. Because most of the seizure patients, after, especially the adults, after their seizure, they feel shy. Imagine we went for party, okay, and somebody started having seizure. Yes, especially the epileptic guys. Epilepsy is a medical condition. Brain injury, as example, TBI, traumatic brain injury. A certain woman was beaten by the husband, okay, and the husband hit something to the head, and there was a brain trauma. Since that day, the woman became paralyzed. With time, when we were managing this woman, with time, she started having seizures, and it was becoming status. It was recurring. So we have to put this woman on sodium valproate and all these levetiracetam medications. Yes. And she was brought to our neuro units. I was working in UK. Neuro units. Okay. And until date, the woman is still there. At the point, she couldn't even swallow. She was having issues with breathing. So we have to do tracheostomy for her. Okay. Yes. So people with epilepsy and all these guys, you'll be seizing, they'll, as you know, sometimes the temperature will go high, sometimes it will be low, sometimes they will be having urinary, reduced urinary output. They are all signs and symptoms. Seizure too is a sign and symptom. But epilepsy guys, when they go out and there is more joy, happiness, they will trigger. Okay. When they get infection, they will trigger seizure as a sign and symptom. After they go through the episode, then they are shy. They are feeling shy. So you should not discriminate against them. It can happen to you and I. We always drive, we always cross the road. Somebody can knock us with a car and run away. Okay. So what are you supposed to do for these people? Their bed. You should pad their bed. Every hospital environment or ward should have side rails. Once the patient inside this bed is a seizure patient or has had seizure before, their bed should be padded. The side rails should be padded like this. Okay. So when you pad it, it prevents injury. Sometimes they will be seizuring. Maybe you are a nurse, you are working with another patient, they're having seizures. Okay. They can have seizures and they will hit their head to the side rails and get injury. So to prevent injury, their bed should be low. Imagine this bed, the patient is here having seizure and he falls down. They can break their bone. Okay, so the bed should be in the lowest. Even when they fall down, the injury will not be that high. Also, oxygen should be available every day, and suction equipment, their room, to suction secretions so that they don't aspirate. IV access in seizure, you want to obtain, especially status epilepticus, you want to stop it. You give IV, you don't do orals. Don't put anything in the mouth of a seizure patient during episodic attacks. Okay? So IV, all these your medications, you stop the seizure. Bam. Okay. Yes. So during a seizure, stay with the patient, never leave them. Lower patient to floor if standing. So those of you in church, we are in church, we are doing praises, everybody is smiling, laughing, then you saw somebody going down. Okay. Yeah. Pastors will be so tired, they don't sleep. They go for program to program. They are preaching from the pulpit. They are coming down. Okay. One pastor went to collapse in somebody's, went at the graveyard. It was online. They don't rest. Okay. If you don't rest your brain, the nerves will show you shaky. Okay. You always turn them on their side. Okay. To prevent aspiration. Losing all restrictive. So this guy, this shoe and all these things, sometimes you cut it. Nurses should have scissors. Okay. David is saying Holy Ghost. Yes, we are praying in church. Somebody has seizure and fell down. They think, oh, this person has it's having Holy Ghost. Okay. So note the time it started and the duration, whatever. Never insert anything into the mouth of a seizure patient. Never restrain them or forcefully hold extremities. After the seizure, some of them will be confused. Okay. So reorient them to the environment. Assess their airways. Document findings. Allow rest. Okay. So a patient begins seizing in bed. The next thing to do, protect airways and turn patient to the side. Yes. Now let's go to fire. Then we say bye-bye for today. So fire, we have 15 minutes. Jesus Christ. So fire safety, if you want to be safe with fire, always go with the acronym RACE. Okay, RACE. So when fire starts, your first action is rescue. Rescue vulnerable around you and rescue yourself. So rescue any person in immediate danger. Okay, yes. Then the A is alert, fire alarm. Alert others by activating. So when you go to the hospital environment, fire burns from chamber to chamber. So every hospital, I don't know if your mind has been drawn to this. Every hospital we build, we make it into chambers, unit A, unit B, unit C. So for you to travel from here to here, you need to pass through this chamber. Even if the fire is burning on the roof, it will burn this roof before it gets to this roof. So you were here and you saw fire in chamber A. You sound the fire alarm and it goes for everybody in other chambers to know. And they will go and check on their panel because the house or the hospital has been wired by electricity. Okay. So once any of the electrical wires get triggered and the fire alarm goes, if I am in chamber C and I go and check on my fire panel, I will see that there is fire in chamber A on the roof at this location on this. That is why we have to sound the fire alarm. Okay, so you are the nurse in chamber C. Do you have to leave your patient and go? No. Okay, you send one of the carers or if you are two nurses, send one. One should go and look at, okay, we want to check our panel. It's like a small monitor on every hospital you go, just watch it. Look for the fire panel. Go and watch it. You will see the map. Sometimes the map too will be beside it. Okay. So you tell whoever you are sending that go and see. Sometimes a false alarm or sometimes a true alarm. Okay. So go. You can send two people that they should go. They will come back with a response that it's true, it's fire. Then if it is fire, what do? We close these doors to contain the fire here. We contain the fire here, or sometimes we start evacuating. Evacuate. Okay. We start evacuating. Evacuate. So you contain the fire, then you evacuate. The race, this acronym should never leave your mind. Because any fire training you go, they will teach you this. You must know this first before you know how to use a fire extinguisher. If you see fire and you don't know how to use fire extinguisher and you don't stop joking and you don't rescue people and you go and waste time with fire extinguisher and people burn, they will jail you. So know your race before you know how to use your fire extinguisher. That is, you are in your house, there is fire at the kitchen. Rescue yourself and the children and whoever is in the house. Okay. And what? I remember one time ago when we were in Ghana, one of the hospitals we were working, there was fire at the OPD. Early morning, fire, smoke everywhere. You can't even see anything at the OPD. Everybody ran away, not knowing one woman has come for wound dressing, and she was sitting in her wheelchair inside the smoke. It was the fire service people who went to bring her out. Imagine the smoke turned to fire, like Wahala come, she will burn alive. Okay. So that is it. Rescue, remove anyone immediate, alarm, confine, close the doors. We have fire doors. We have some doors that fire cannot penetrate easily. We call it fire doors. If you build your house in future and you have money, buy fire doors for your house. Okay. Yes. Then you extinguish or you evacuate. If you don't know how to use the fire extinguisher, this is how I'm going to show you. Okay. So this is the fire extinguisher. Before you use the fire extinguisher, know this acronym. We call it PASS. Okay. PASS. But before you know PASS, know your race, because race will save lives. Your duty is not to learn how to be a master of fire extinguisher. Your duty is to save life as a nurse. Sometimes you know how to save life, fire extinguisher, you know how to use it. But going to use fire extinguisher will waste time. So why don't you stop it and go in? Because the ambulance people are coming. Okay. Yes. In UK, most of the care homes in UK, their fire panel is connected to the fire service office. Okay. There was one care home I was working in Sunderland, and at dawn, the fire alarm went off. Within 5 minutes, the fire service was in the care home. Because once the fire alarm goes off, it notifies them in their office that this care home, there is fire. And they came within 5 minutes. They were there. And when they came, it was a false alarm. One of the residents went to press there. Because most of these dementia patients, they like color. And the fire alarm is a red color. So you went to press it, break it, and okay. Break it and press it. Okay. So that is it. So fire extinguisher, this is how we do. The acronym is PASS. That is PASS. Okay. So you see the extinguisher here. You first pull that safety pin. Every fire extinguisher has a safety pin here. Pull it, remove it. Okay, pull it. So when you pull it, now it gives you the aim to press the lever. Okay. Yes. So After pulling the safety pin, you hold this part and target, you aim. So you see this one is lying down, but on this aim, you are holding this part to target the fire. Use it to like focus on the fire. Okay. You aim the base of the fire. Then you squeeze it because you have already removed the pin here. Okay. So you squeeze. When you squeeze, the fire will come. Okay. And as the extinguisher is dispensing, you sweep, move from side to side, like the way you are sweeping your house with your broom. You sweep the base. Don't spray the top of fire. If you see fire like this, okay, this is the top of the fire, and this is the base. This fire you are seeing here, they are getting their energy here because at the base here, there is a combination of energy, oxygen, and all those kind of sources that is fueling the fire. Okay. So what do you have to do? If you spray here, you are not targeting the problem. The problem is from here. Solve the problem. So the nozzle or the mouth of the fire extinguisher, okay, with this thing like this, with the bottle like this, then so you should what? Target here. Whether the powder, whether carbon dioxide, whether foam, whatever, so many types. You should target the base and you blow it and you sweep. So you sweep like this, sweep like this, sweep like this. Fire. If you try one and it doesn't stop and it's becoming, leave this thing down and save yourself and others. That's it. So you are extinguishing a water basket fire. Aim where? The base. That is it. So guys, there are so many questions for us to answer, but because of time, I'll give the slide to you because we need to go and watch our match. Okay. So when you get, I'll put some questions on the page. Try and solve it. Okay. And this is the end of today. These are all questions. So try and solve it. Okay. Solve it too. Thank you. Remember, don't forget to subscribe to our channels. If you are not part of the WhatsApp group, join. Okay. Subscribe to our channels and be with us. Okay. Thank you so much and God bless you. Okay. Thank you. Hey, have you scored?
Thank you so much, sir.